So welcome everyone. Welcome to our Zoom meeting. I hope everyone is doing great. So today we will cover different topics, and the yellow team is going to take care of the presentations. So, and here's the agenda. So we'll talk about the cardiovascular disease part 2, some ethics. We will have Dr. Mohamed Miqdad. He will join us later. He was one of the fellows in this program, and he will share his experience. I will go over some other skills like leadership skills and data analysis. I'm gonna stop sharing the screen, and I think Dr. Nada is here. Welcome, Dr. Nada.
Hi, Dr. Nader. How are you doing?
Very good, thanks. Thank you and your team in advance. So I'm gonna hand it to you.
Thank you so much. You too. My name is Dr. Nada Dahrouk. I'm gonna be the moderator today for today's meeting, and I'm the team leader for Team Yellow 1. So we're first gonna start with the cardiovascular disease part 2. We have 4 fellows who are gonna present. We're gonna start with Dr. Safa. Is Dr. Safa here?
Yes.
Okay. So Dr. Safa, you're the first presenter, right? Okay. Can you share your screen, please?
It say only the host can share in this meeting.
Dr. Safa, can you try it again? Oh, sorry. I gave it to Safa. Kaleem. Let me try again. So, Safa Mohammed.
Yes.
Okay, try again. Please and thank you.
Hello, everyone. My name is Safa. So we're gonna start with the valvular disease. This is the 4 type of valvular disease: the aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation. This is the most important and serious one. There's pulmonary stenosis, pulmonary regurgitation, but the other are not serious, not important as these 4 types.
Dr. Safa, if I may ask you, did you share your screen?
Yeah, you see it?
No.
Okay, let me try one more time. Okay, you're supposed to see it right now, right? It showed the PDF?
Yes, we can see it now.
Okay. So we're gonna start with the introduction. The prevalence of aortic stenosis increase with age, approaching 15%. And aortic stenosis is the most common valvular abnormality requiring intervention in older adults. Also, aortic regurgitation may be acute or chronic. The incidence of both increase with age, is not usually severe enough to require surgical intervention. Rheumatic mitral stenosis is uncommon in older adults in the United States, but occasionally patients in their 70s, 80s present with the symptoms to previously undiagnosed rheumatic disease. So the diagnosis may be established incidentally when the patient undergo echocardiography for another reason. For example, a new onset of atrial fibrillation, and most commonly mitral stenosis in older adults due to non-rheumatic calcification of the mitral valve. Mitral stenosis may be acute or chronic. It is present in up to 1/3 of older adults, but only small portion require surgical intervention. How we diagnose the valvular disease through echocardiogram. So for aortic stenosis, echocardiography is essential for assessing disease severity, evaluating left ventricle function, and determining the presence of associating valvular lesion. In patients with acute severe aortic regurgitation, echocardiography demonstrates a short duration aortic regurg jet with rapid declaration and premature closure of the mitral valve. Echocardiography with Doppler can be non-invasively assessed that cause non-invasively assess the cause and severity of most acute or chronic valvular abnormalities. So the first approach is the echocardiogram, and we can use the Doppler too. So in this slide, it showed the symptoms and the finding and the treatment for each valve. For example, the aortic stenosis. So the clinical symptoms may patient go through angina or symptoms of heart failure, syncope, light headedness. These all symptoms can be present. On the physical exam, you may found mid-late systolic ejection murmur radiating to carotid, the S4, gallop left ventricular heave. On the ECG, we may find left ventricular hypertrophy, and the treatment medical treatment is not effective therapy. We can use the transcatheter aortic valve replacement, but in selected patient. Surgical intervention is the best choice, and it indicates in severe aortic stenosis with symptoms, with severe symptoms. Prosthetic valve is preferred in the older patients. For aortic regurgitation, the symptoms can be acute or chronic, may be asymptomatic, minimally, or symptomatic, mildly, moderate. It can be dyspnea on exertion, can be symptoms of left ventricular hypertrophy. On the physical exam, you may find high pulse pressure, bonding collapsing pulse, and the murmur, systolic ejection murmur. On the ECG, you may find the left ventricular hypertrophy as well, and the In the acute aortic regurgitation, you may find the tachycardia. On the chest radiography, the chest X-ray, you may find the cardiomegaly. This is on the severe chronic aortic regurgitation. You could see the pulmonary congestion in the acute aortic regurgitation. The treatment in the less severe cases, the medical treatment may help with controlling the hypertension. But the surgical intervention is an option for acute severe aortic regurgitation for the symptomatic severe chronic, asymptomatic severe chronic aortic regurgitation. With the left ventricular ejection fraction of less than 50% of left ventricular end-diastolic dimension of more or equal 5 centimeter. Okay, for the mitral stenosis, the symptoms mainly can be dyspnea on exertion, orthopnea, and the edema. On the examination, on physical exam, you may find early diastolic opening snap, the rumbling. You may find diastolic murmur at the apex, pulmonary hypertension, and right heart failure. For the treatment, the medical may be the diuretic for the volume overload. So your patient have edema, the diuretic will be helpful. The beta blocker to decrease exercise tolerance associated with the tachycardia. The balloon valvoplasty may be safe and effective, but most older adults are not good candidates due to extensive calcification. So surgical mitral valve replacement is effective, but with 5 to 15% operative mortality in older patients. The last thing is mitral regurgitation. Can be acute or chronic. It can be present with the shortness of breath or dyspnea in acute, severe mitral regurgitation, progressive shortness of breath, and dyspnea on exertion in chronic mitral regurgitation. On the physical examination, the tachycardia, the narrow pulse pressure, the S3, and short, harsh systolic murmur in acute mitral regurgitation. Holosystolic murmur radiating to axilla, pulmonary hypertension, as I said, and right heart failure in chronic severe mitral regurgitation. For the treatment, the medical treatment may include all right. So for the medical therapy, as for heart failure with systolic dysfunction in patients with symptomatic chronic mitral regurgitation, and left ventricular ejection fraction less than 60% who are not candidate for the intervention. This is the group who are which the medical treatment could help them. Transcatheter mitral valve repair is in selected patient, and surgical intervention mitral valve repair preferred over mitral valve regurgitation. Bioprosthetic valve preferred over mechanical in older patient, all effective within 5 to 15%. Operative mortality in older patient, operative mortality is lower for the repair than the replacement.
Hi, Dr. Safa. If you don't mind me interrupting, everybody's saying the screen is too small. So if it's okay, I can share my screen instead, and you can tell me when you want to change the slide. Would that be okay?
Yeah, sure.
Okay. Dr. Nader, if you can make me the host, I'm gonna share the screen and then we can continue with the presentation.
Just a second.
Okay, can everybody see my screen?
Yeah, it's good.
Yes.
Yeah, I can see yours.
It's clear?
Yes.
Yes,
It's
very
clear.
Yeah.
Okay, thank you. Dr. Safa, let me know if this is the slide that you were in, and then you can continue from there. Was it this one or before it?
The next one, please.
The next one? Okay. Go
All
ahead.
right, so this is the indication for the surgical intervention. As we mentioned before, when the patient had acute or severe mitral regurgitation with the heart failure, it should be indication for the surgical intervention. And the mitral regurgitation, most patient came asymptomatic. They discover it like accidentally, but when it becomes symptomatic, with severe chronic mitral regurgitation, it can be indication for the surgical intervention. The left ventricular ejection fraction should be more than 30%. Asymptomatic patient with severe chronic mitral regurgitation and left ventricular ejection fraction 30 to 60%, and or left ventricular in systolic dimension of equal or more than 4 centimeter. When mitral valve repair is deemed likely to be successful in asymptomatic patient with severe chronic mitral regurgitation, and in left ventricular ejection fraction of more or equal 60%. Also in patient with severe chronic mitral regurgitation and pulmonary artery systolic pressure more than 50, or new onset of atrial fibrillation. So new arrhythmia is indication for the surgical intervention with high likelihood of successful mitral valve repair. All right. Transcatheter aortic valve replacement with bioprosthesis is associated with improved outcome relative to medical therapy in older adults who are not candidate for a surgical aortic valve replacement, so they can go through this procedure. It's gonna be shorter hospital length, of stay and faster functional recovery. Vascular complication and stroke are more common after the transcatheter aortic valve replacement, but major bleeding and atrial fibrillation are less common. In patients who are high risk for surgical aortic valve replacement, but major bleeding, in patients who are high risk for surgical aortic valve replacement, transaortic valve replacement has demonstrated similar or better outcome up to at least 3 to 5 years, including risk of stroke, vascular complication, and all-cause mortality. So we're gonna go over the infective endocarditis. Since the early part of the 20th century, infective endocarditis has undergone transformation from a disease of young adult with a rheumatic or congenital valve anomaly to one of the older adult with a degenerative valve disorder or prosthetic valves. Less frequently, infections are due to HACEK organism. It's a group of gram-negative rod that primarily inhabit the oral cavity and include the genera. The names are Haemophilus, Actinobacillus, Cardiobacterium, Ignella, and Kingella. I'm not sure about the pronunciation, but you can search for the names for the organism. It's for the organelles, okay? Also, there is other atypical pathogens. The negative staphylococcus are a common cause of prosthetic valve endocarditis, particularly in the first 60 days after the valve replacement. Transesophageal echocardiography improve the diagnostic yield for the infective endocarditis, but the lack of positive finding on transesophageal echocardiography does not exclude the diagnosis. The treatment, okay, in the absence of major comorbidities, age does not appear to apply a major role in mortality risk, within a 2-year survival of 75% for infective endocarditis in all age groups. And the treatment, it could be the IV antibiotic, regard the causative organelles. The surgical therapy should be considered. In the presence of severe valvular dysfunction, we should consider the surgical intervention. Also, recommendation for preventing endocarditis after dental procedure, focus on providing prophylaxis only in the highest risk patient. Those who are with the prosthetic valve, prior endocarditis, certain congenital heart disease, cardiac transplantation, valvular disease in general. And recent guidelines have eliminated recommendation for prophylaxis for those undergoing GI or GU procedure. They should be considered the prophylactic too. And that's it for today. My colleague gonna continue the rest of the presentation. Thank you, guys.
Hello, Assalamu alaikum, Dr. Nader, Dr. Nada, and everyone. So, Dr. Nada, I'm Safa Kaleem. I will be presenting about cardiac arrhythmia. So, will you be sharing the screen, or should I share my screen?
No worries, just I'm gonna share it and you can continue and let me know when you want to change the slides.
Sure, thank you. Okay, so a little introduction about myself. I am Dr. Safa Kaleem from Hyderabad, India. And I completed my step 1, 2, and 3, and inshallah, I will be applying for internal medicine in the upcoming math cycle. And today I will be presenting about cardiac arrhythmias. So let's start with it. So as we all know that cardiac arrhythmias means irregular heartbeat, which occurs due to abnormal electrical signals originating from the heart. Arrhythmias can be both due to increase in heart rate that we call as tachyarrhythmias or decrease in heart rate that we call as bradyarrhythmias. And so the age-related changes in cardiac conduction system coupled with increasing prevalence of cardiovascular disease at older age leads to progressive increase in the incidence and prevalence of conduction abnormalities, heart rhythm disturbances in older adults. And age-related degenerative changes in and around the sinoatrial node and atrioventricular node leads to increase in bradyarrhythmias with advancing age. Yeah. So there are different types of, first we'll be going with the tachyarrhythmias. So within tachyarrhythmias, we have two types, that is the supraventricular and the ventricular. Supraventricular is anything that originates from above the ventricles. So the supraventricular arrhythmias include atrial fibrillation, atrial flutter, multifocal atrial tachycardia, paroxysmal supraventricular tachycardia, or AV node reentrant tachycardia. First, we will be going through the atrial fibrillation. So atrial fibrillation is the most commonly sustained arrhythmia, which we see in the clinical practice. The most common risk factors for AFib are hypertension and coronary artery disease. The incidence and prevalence of AFib increases exponentially with age, such that the prevalence in octogenarians, that is the one who are in their 80s, is approximately 10%. And among older patients with valvular heart disease or heart failure, the prevalence is even higher, approaching towards 30% increased risk. So the symptoms related to AFib are highly variable, and the most common include the patient may complain of palpitation, like he can hear his heart beat very fast, or may complain of shortness of breath or impaired exercise tolerance. And the first diagnostic test we do is an EKG. And on the EKG, we can see an irregular rate and irregular rhythm with no distinct P waves. Once the diagnosis with EKG is made, then we can proceed with echocardiogram and serum electrolytes, especially potassium and magnesium, to rule out the long QT syndrome, and also thyroid function test. Further evaluation in selected cases may include chest X-ray, serial cardiac biomarker proteins, brain natriuretic peptide level, a D-dimer level, lower extremities venous Doppler, and an evaluation for pulmonary embolism. And we also have to look out for the, because AFib, for AFib, the most dreaded complication is thromboembolic events and stroke. We'll talk about it later. But coming to the management of atrial fibrillation, so our main objective will be to relieve the symptoms and then to control the rhythm and to minimize the risk of thromboembolic events, particularly the stroke. So the principal strategies for relieving symptoms include control of heart rate and maintenance of normal rhythm. So to maintain the heart rate, we give drugs like beta blockers and calcium channel blockers. And patients who experience a significant shortness of breath, fatigue, or exercise intolerance attributable to AFib, it may be managed with antiarrhythmic drug therapy, which is aimed at maintaining the sinus rhythm. And as we all know, the antiarrhythmic drugs include 4 classes. That is sodium channel blockers, the beta blockers, the potassium channel blockers, and the calcium channel blockers. And then alternative to antiarrhythmic drug therapy, we have a catheter ablation of the arrhythmogenic foci, which is usually to the pulmonary vein isolation. Or we can also approach surgically, that is the surgical mace procedure. So in the surgical mace procedure, the surgeon usually creates a scar like a mace, a scar tissue in the upper chamber of the heart to block any faulty signals that may cause the conduction leading to arrhythmia. And all other patients with paroxysmal or persistent AFib, they require consideration for stroke prophylaxis. Yeah. So for the stroke risk stratification, we follow the Chadvask score, wherein C stands for congestive heart failure, H for hypertension, A for age greater than 75, which gets a score of 2, diabetes, a stroke or thromboembolism, vascular disease, age 65 to 74, and female gender. So if the Chadvask score is greater than or equal to 2, then that patient is a candidate for systemic anticoagulation. We also follow the Hasbled score, which may be an useful adjunctive tool to promote informed decision making by estimating a patient's annual risk of major bleed. So for the Hasbled score, H stands for hypertension, A for abnormal liver or renal function, S for stroke, B for bleeding, L for labile INR, E for elderly age that is greater than 65, D for any drugs or alcohol, each accounting to 1 score. And if the score is greater than or equal to 2, then the patient requires a regular follow-up monitoring along with the anticoagulation. Yeah. And so the drugs we use are warfarin titrated to maintain an INR of 2 to 3, and aspirin 75 to 325 along with with or without clopidogrel. But the active W trial demonstrated that warfarin is superior to the combination of both aspirin and clopidogrel in terms of both risk of ischemic stroke and also major bleeding in patients with AFib. Then we also use direct oral anticoagulants, and the 4 oral anticoagulants that we use are apixaban, dabigatran, rivaroxaban, and edoxaban. And for AFib patients with elevated Chadvask score, in whom chronic anticoagulation is contraindicated, then consideration should be given for a percutaneous left atrial appendage closure via the Watchman device. Yeah, then coming down to the next type of supraventricular arrhythmia is the atrial flutter. So atrial flutter, it usually originates from the re-entry circuit around the tricuspid annulus in the right atrium. And the EKG, on the EKG, we see sawtooth P waves. And it usually occurs in older patients with concomitant AFib, and both anticoagulation and rate control considerations are similar to that of AFib. And patients with typical atrial flutter that is either symptomatic or is refractory to pharmacological rate control should be considered for a catheter atrial flutter ablation. We can do the atrial flutter ablation between the tricuspid annulus and the inferior vena cava. Then the next types include atrial tachycardia, AV node reentrant tachycardia, and multifocal atrial tachycardia. So multifocal atrial tachycardia, again, on EKG, we see irregular rate and irregular rhythm with at least 3 different P wave morphologies, and it occurs due to multifocal ectopic foci in the atria. It might be associated with COPD, pneumonia, or heart failure, or any underlying conditions. So For the treatment, we have to treat the underlying condition and provide pharmacotherapy aimed at rate control or arrhythmia suppression. In selected patients with recurrent symptomatic episodes, antiarrhythmic medications or catheter ablation may be considered. Yeah, now moving on to the ventricular arrhythmias. So frequent ventricular premature beats, ventricular couplets, and short runs of non-sustained ventricular tachycardia. So if the patient is asymptomatic, then we do not give any treatment, any therapy. But if the patient is highly symptomatic, then we give a beta blocker as the treatment of choice. And longer episodes of ventricular tachycardia with dizziness or syncope, then a referral to a cardiologist or electrophysiologist for consideration of antiarrhythmic drug therapy or catheter ablation or implantation of a cardiac defibrillator. For secondary prevention is required as people with a VTAC have high risk of sudden cardiac death. Yeah. And then coming to bradyarrhythmias, previously we were talking about tachyarrhythmias, now bradyarrhythmias. So patients with bradycardia, they usually have a resting heart rate ranging from 50 to 60 beats per minute, and they're often asymptomatic. But patients with more marked bradycardia, that is the resting heart rate is from 40 to 50 beats per minute, they may experience fatigue, lightheadedness, especially when they are standing, and they may also have reduced exercise tolerance. Pre-syncope or syncope may occur in patients with profound bradycardia, that is if the heart rate goes below 40 beats per minute, or asystolic pauses for greater than or equal to 3 seconds. It might be due to sinus dysfunction or heart block within the AV node or infranodal conduction system. Yeah, so for the diagnosis part, we first need to find out what is the exact cause of bradyarrhythmia. So we need to first exclude significant electrolyte abnormalities like decrease in calcium, potassium, magnesium, or increase in potassium. And we also have to check out for the thyroid functions to exclude if there is any hypothyroidism. And we have to also review if the patient is on any of the medications that might cause bradycardia, like beta blocker, digoxin, lithium, or TCAs. And unexplained pre-syncope or syncope. For that, we need to do carotid sinus massage to evaluate for carotid hypersensitivity. An abnormal response to carotid massage, it is defined as an unequivocal reproduction of the patient's symptoms like syncope, asystole lasting greater than 3 seconds, or a decrease in systolic blood pressure for more than 50 mmHg in the absence of symptoms, or decrease in systolic blood pressure for more than 30 mmHg in association with symptoms like dizziness or pre-syncope. Yeah, so now if the symptoms occur daily or almost every day, then a 24 to 48 hours ambulatory monitor may be helpful for confirming or excluding bradycardia or other heart rhythm disorder as the proximate cause. But if the patients whose symptoms, they occur at least once a month, but not daily, then a 30-day event monitor may provide a definitive diagnosis. But in patients with rare, that is less than monthly events, but recurrent symptoms of a serious nature, like the patient may have syncope leading to injury, then an implantable loop recorder may be considered. So for the management of bradyarrhythmia, we have to first correct any treatable cause, like if there is any electrolyte abnormalities, if it is hypothyroidism that is the cause, or we can eliminate potentially offending medications if possible. Then in patients with confirmed symptomatic bradycardia, which is not responsive to conservative management, then a permanent pacemaker implantation is necessary. Yeah, with this, I come to the end of my presentation, and my colleague, Dr. Sara, will be continuing further. Thank you, everyone.
Assalamu alaikum. My name is Dr. Sara Omer. Thank you for this great opportunity. Thank you, Dr. Nader and Dr. Anada. And I'm happy to present today peripheral arterial disease. Okay, let's get started. Peripheral arterial disease encompasses disorder of the abdominal aorta. What we will discuss today is abdominal aortic aneurysm. and we have renal and mesenteric artery. We will not go into these, but renovascular hypertension is really common cause of resistant hypertension in elderly population. And we have iliofemoral and popliteal arterial tree, which we will discuss with the lower limbs peripheral artery disease. So the prevalence increase with age, and it's higher in men than in women. It's like the coronary artery disease, okay? And risk factor is more or less the same. We have the modifiable risk factor like hypertension, diabetes, cigarette smoking, and to a lesser extent, in older adults, we have a family history, okay? And regarding abdominal aortic aneurysm and the symptoms, can we go to the next slide? Okay, at least 50% of the patient with peripheral artery disease are asymptomatic. Patients with abdominal aortic aneurysm are usually asymptomatic in early stage, and as aneurysm enlarge, they may notice abdominal pulsation or experience like back pain or abdominal discomfort, less commonly neurological symptoms. So we need really high index of suspicion, okay? And symptoms of peripheral of lower limbs peripheral artery disease include claudication, claudication with exertion, what we call intermittent claudication. And here we have to ask our patient, when you walk, are the pain in your lower limbs prevent you from continue walking? If they say yes, we need to know the distance, what we call claudication distance. This is really important in terms of management. And also we have we should recognize the skin changes related to chronically impaired circulation in advanced and in advanced cases we can see ulcer, dry gangrene, and even breast pain. This is happened in critical limb ischemia, which is an emergency. Also, in the examination, we can find a pulsatile abdominal mass. This is regarding abdominal aortic aneurysm, and we can hear a bruit due to turbulence blood flow over the renal and femoral arteries. And regarding lower limbs, we can lower limb peripheral arterial disease. We can notice diminished pulsation and skin changes. Okay. So as I mentioned, we need a high index of suspicion because so many patients attributed their symptom to other disorders. And the most important investigation we run to diagnose peripheral artery disease is ankle brachial pressure index. Okay, it's a ratio of systolic blood pressure obtained at the ankle to the blood pressure obtained over the ipsilateral brachial artery. The normal is from 1 to 1.4. If it's less than 0.9, this is 95% sensitive and 99% specific for leg peripheral artery disease. And if it's more than 1.4, this is associated with non-compressible arteries. This is what we see in older patients with atherosclerosis or long-standing hypertension. And if it is less than 0.4, this is associated with a critical peripheral artery disease or critical limb ischemia, which indicates severely impaired perfusion of the distal limb. Okay, and we can have exercise with treadmill test, which is very important, and we can do it with the ankle brachial index, which will help more with the diagnosis. Also, if patient have moderate or severe symptoms and an abnormal ankle brachial pressure index should undergo additional evaluation if percutaneous or surgical revascularization is contemplated. We can do imaging like CT angiography, MRI angiography, or we have Doppler flow velocity measurement and ultrasonic duplex scanning. Okay, and as I mentioned, the most important point is formal history and physical examination and we need to screen for symptoms and sign if peripheral artery disease is recommended is recommended for a patient from 50 to 69 with risk factor for atherosclerosis, and for patient more than or equal 70 with or without risk factor. Okay, and it's important, really important, to screen men over 60 with a family history of abdominal aortic aneurysm, and men from 65 to 75 here who have ever smoked should undergo abdominal ultrasound to screen for abdominal aortic aneurysm. Okay, next. Regarding treatment, as I mentioned, it's like coronary artery disease. So we need to give them aspirin, 75 to 325 milligram. If the patient cannot take aspirin for whatever reason, we can give him clopidogrel. And we can give combination of aspirin and clopidogrel for at-risk of vascular event patient and acceptably low risk of bleeding. Okay, and we can give ACE inhibitor or ARBs for prevention of cardiovascular event in patient with symptomatic peripheral artery disease. And the most important is exercise regularly. Another point is the smoking cessation also should be strongly encouraged in any patient who are interested in a smoking cessation should be counseled about that. Patient with significant lower extremity peripheral artery disease should engage in regular exercise program under supervision. Exercise should include walking for at least 30 to 45 minutes, at least 3 times a week for a minimum of 12 weeks. Also, it's really emphasize the importance of exercise, even it's more important than the pharmacotherapies. The greatest improvement in walking ability occur in individuals who exercise to near maximal pain threshold for a period of 6 months. Okay, that's and the point also I want to emphasize is that peripheral artery disease is considered coronary artery disease risk equivalent. It indicates that patient with peripheral artery disease have 20% risk of experiencing new coronary event within 10 years. And even and if the patient is comorbid with diabetes or have established coronary artery disease, the risk is even higher. Finally, the revascularization is indicated in patients with severe symptoms attributable to peripheral artery disease that have not responded to aggressive risk factor modification and exercise and pharmacotherapy. Regarding pharmacotherapy, the established with the strong evidence is phosphodiesterase inhibitor type 3 cilostazol, with a dose of 100 milligram every 12 hours. Increase the maximal walking distance by 40 to 60%. And also we have pentoxifylline, but it's the benefit is marginal. Also, we have percutaneous transluminal angioplasty with or without stenting. Versus we have also surgical revascularization. These all depend on the lesion location and the severity of likelihood of success, and even the expertise of the interventionist or the surgeon. It's importantly, these two therapeutic approach should be viewed as complementary rather than competing strategies. And the choice of revascularization should be tailored to the individual patient's circumstance and preference. Okay. and its revascularization is also indicated for patients with critical limb ischemia, those who present with severe wrist pain, pain at rest, I mean, and ulceration or gangrene. Okay, and these patients really in need of emergent revascularization. Next, please. Now is abdominal aortic aneurysm. The indication for repair is a development of symptoms, rapid aneurysmal dilation detected during serial assessment, more than 1 centimeter in one, or more than or equal 1 centimeter in 1 year. This change is indication for repair. I mean 0.5 in 6 months, because we run the assessment every 6 to 12 months by ultrasound and check the diameter. Okay, and the choice of open or endovascular surgical repair depend on a lot of factors. On the location, first of all, the location of the lesion and the patient comorbidities and prognosis. Okay, open repair is favored for suprarenal abdominal aortic aneurysm and for patients with fewer comorbidities and life expectancy more than 10 years, because this procedure has reduced rate of long-term leakage and rupture. And endovascular repair is suitable for patients with infrarenal abdominal aortic aneurysm because it has a higher, and if the patient have a higher surgical risk and lower life expectancy because it's associated with lower perioperative complication and mortality. So the most important is we should know the indication, the rate of changes, and if it's the patient are symptomatic or not. And according to that, we should run into the management. That's all. Thank you very much. And my friend Safa will continue.
Assalamu alaikum wa rahmatullah. Hello everyone. My name is Safwa al-Mahdi. Thank you, Dr. Nadir, for giving us this opportunity. Thank you, Dr. Nada, and I will continue the presentation, inshallah. So, we have a shared decision-making in cardiovascular disease. Shared decision-making entails patients expressing their preference and values and clinicians providing relevant details of the risk and benefit of treatment. We have a patient decision aid for implantable cardioverter defibrillator and left ventricular assisted device implementation. If you want to go through another information, you can go through this link. And also we have a myoclinic decision aid for potential benefit of statin. Okay, next slide, please. Okay, we have a summary. We have a calcific aortic stenosis is the most common valvular abnormality requiring intervention in all the adults. We have a surgical aortic valve replacement is the standard treatment for aortic stenosis in healthy older adults, while transcatheter aortic valve replacement is an effective alternative in older adults at moderate to high risk for surgery due to comorbidity, frailty, or other factors. Atrial fibrillation increases in prevalence with age, and more than 50% of all patients with atrial fibrillation are aged 75 years or older. Most older patients with atrial fibrillation respond to rate control medication plus antithrombotic therapy, but some require antiarrhythmic drug therapy or other intervention. Next slide. Next slide, please. The prevalence of peripheral artery disease increases progressively with age, and peripheral artery disease is a potent risk marker for concomitant coronary artery disease and cerebrovascular disease. Management of peripheral artery disease should include appropriate treatment of hypertension, dyslipidemia, diabetes, and tobacco abuse in accordance with existing practice guidelines. Okay, we have a cases here. Case 1. An 82-year-old man has been progressively short of breath with exertion over the past several months. He had been healthy throughout his life with no risk factors for cardiovascular disease. On examination, hemodynamic findings are normal at rest with no postural changes in blood pressure. Jugular veins are distended 6 centimeters. They are bilateral pulmonary curtains. There is +1 pedal edema, but no calf, pain, or swelling. So we have a patient with heart failure, most likely due to valvular heart disease and aortic stenosis. It is most likely. So we can continue. Which one of the following should be ordered first for this patient? Okay. So, yes, the correct answer B, transthoracic echocardiography. Always, if we want to diagnose a patient with heart failure most likely due to valvular disease, we should select echo. Echocardiography, it is the diagnostic modality of choice. Okay? Next slide. Yes, transthoracic echo. Case 2. An 84-year-old woman comes for a routine visit. She is concerned about the number of medications she takes and asks why she needs to take preventive medication for cardiovascular disease at her age. She had a small non-ischemic 12 years ago, non-ischemic myocardial infarction or non-ischemic elevation myocardial infarction 12 years ago, but no cardiac symptoms yet. She is well controlled on her medication. Medications are amlodipine, atorvastatin, metoprolol, metformin, acetaminophen, and aspirin. All of them are a medication which work like prophylaxis from another attack. She usually walks up and down her block every day with no compensation. With no decompensation, she has been missing this walk more frequently because of fatigue. Examination: we have a blood pressure 130/80, heart rate 60. Recent lab result: hemoglobin A1C 7.5 and LDL cholesterol 80 mg per deciliter. Okay, which of the following is the most reasonable recommendation for this patient? Yes, the correct answer is D, resume her regular walking program. Yes, yes, because she already on her medication, is well controlled on them, and lifestyle it is the most important thing in patient also with cardiovascular disease. Exercise is most important thing. Yes. Next. An 88-year-old man comes to the office for a consultation. He has had progressive shortness of breath on exertion. He has recently had chest pain and dizziness when he walks. His surgeon says that he is too frail for surgery, but might be a good candidate for transcatheter aortic valve replacement. Okay. Which one of the following should be considered in the management plan of this patient? Yes, the correct answer. Yes, it is A. A transcatheter aortic valve replacement may be less effective for patients who have concomitant mitral regurgitation and pulmonary hypertension. Here we have a critical medical assessment must be integrated with disease-independent domains such as frailty and cognition for a holistic perspective. Medical and disease-independent vulnerabilities such as severe mitral regurgitation and pulmonary hypertension can blunt the utility of transcatheter aortic valve replacement. Complex issues of frailty and cognitive impairment affect transcatheter aortic valve replacement outcomes. Gauge speed is often applied as an index of frailty, but strict cutoffs are problematic. For example, patients who have slow gauge speed from deconditioning may improve after the procedure. Other gigs, including a composite of hematocrit, nutrition, strength, and cognition, have proved better than gauge speed alone for predicting frailty and poor outcomes in transcatheter aortic valve replacement patients. Some patients with mild or even moderate cognitive impairment may derive functional and qualitative benefit from transcatheter aortic valve replacement. And thank you so much.
Thank you, all of our 4 presenters, for the great presentation. If any of the fellows have any questions, please feel free to ask them regarding the cases, regarding the presentation itself. Thank you, everyone, for the great feedback, and thank you for the presenters for all of your hard work. Dr. Nader, if you have any comment, please let us know.
This is great presentation for all the presenters. Thank you so much. Great work. Thanks.
If there is no other questions, then we could go ahead with the topic number 2. For topic number 2 is going to be considering about the ethics, and we have Dr. Isra. She's going to present. I'm going to share my screen now, and Dr. Isra is going to present. Dr. Isra, are you ready?
Yes, I'm ready. Thank you, Dr. Nader and Dr. Nada, for providing me with this opportunity. My name is Dr. Isra Eltayeb, and I will be talking about the ethics of red doctors and clinical educators. Next slide, please. Now, I will start my presentation by stating the problem. Now, society has endured economic downturn, and healthcare consumes too much of country's economy, pushing out other government programs, such as police, military, and education. The never-ending new health technologies such as PET scan, MRI, and never-ending technologies have increased the cost. Thus, the rising cost of healthcare is unsustainable. Now, doctors are experts who need to find a solution for this problem, so they need to help society decide what it can afford in terms of healthcare. Public health measures are much more cost-effective than individual care, and this goes without explanation. Now, advances in genetics can help predict disease liability and resource utilization. For example, example, in patients with syndromes like familial cancer risk is 100%, so they need to undergo proctocolectomy in order to prevent cancer from occurring. They will also require to undergo surveillance endoscopy. So it's the doctor's role to predict the disease liability and to identify these patients. Fastidious medical records improve care, and system innovations can prevent errors. For example, making online lists for sign-in protocol prior to surgery. Now, the sign-in protocol includes information about the site of surgery, the name of the patient, whether the patient is allergic to certain medication or not. Now, this list reduces the risk of errors, such as giving a medication that could cause allergic reactions. And these systems can eventually prevent errors. Next slide, please. So the solution for this problem is through primordial prevention. Doctors should help in promoting healthy lifestyle, and they should aid in smoking cessation. For example, they should open the subject of smoking cessation in each and every visit in the clinic. And they should also help in avoidance of high-risk sexual behaviors. And they should help in exercise and health maintenance by educating their patient in every healthcare visit. Doctors identify individuals who are likely to consume healthcare the most. For example, the geriatric community consumes healthcare the most due to their problems with cognition, and they are likely to have dementia. They also have multiple screening and multiple vaccination, so they consume healthcare the most. Now, as we mentioned, systems reduce errors. Just like we mentioned before in the sign-in protocol. Also, hand washing and fastidious medical record system, as well as checklists, routines, and regimentation provide consistency and will reduce errors eventually. As for the advanced solution, good doctors report the birth of cognitively and physically impaired infants and encourage families to place them in government centers where professional care can be delivered less expensively. Good doctors use their influence and knowledge of modern science to instruct society about the use of cost-effective care. Now, this is a disclaimer that the best individual care is cost-effective. There's no need for unimportant tests and lab results if, for example, a diagnosis can be done clinically. Now, overutilization is not only costly, but it's also dangerous. For example, unnecessary imaging or X-rays can add radiation risk to the patient. And errors are unavoidable. Errors are essential for us to progress. Otherwise, we'll be practicing medicine the same way our ancestors did, and we will not evolve. Now, this is a case that Dr. Martin Samuels encountered. There's no multiple choices in this case, so I'd like you to interact with me in the chat. So, a 60-year-old lady came with a new type of headache that has been worsening over the past 2 months. It comes in attacks lasting 20 minutes each. The headache is non-pulsatile eye pain without any autonomic features. There's no aura, and there's no history of migraine. The patient is a doctor, and her headache is interfering with her work. Her general and neurological examination are normal. A primary doctor has already seen her several times, ordered many blood tests, and tried many analgesics. However, none of them worked. It's worth mentioning that her ESR is equal to 5. What's your diagnosis? Cluster headache. Okay, refer to neurology. Okay. Tension headache. Malingering or tension headache conversion. Okay. Tension, headache. Okay. Can you please go to the next slide? Okay, so this is a rare condition actually. It's known as episodic paroxysmal hemicrania. Now, this condition is actually diagnosed only clinically, and it has a very typical presentation. It presents as a non-pulsatile eye pain without any autonomic features, and that's what differentiates it from the cluster headache. There's no aura, which differentiates it from migraine. She also has no history of migraine. And what's very typical about this condition is that it comes in attacks lasting 20 minutes each. So she doesn't need to undergo imaging. And the only treatment for this condition is indomethacin for a couple of weeks, and then indomethacin is tapered down, and then the condition will be resolved. So next slide, please. So even though this condition is actually diagnosed clinically, the patient asked for brain imaging. She's a doctor, and she was scared that she might be having a brain tumor. It was enhanced by her knowledge of medicine and growing concern about medical errors. The doctor reassured her. Reassurance was helpful, but it wasn't adequate. If you were in the doctor's shoes, would you order brain imaging, even though it's not required? No? Okay. No. Okay. Yes. Yes. Okay. I think yes. 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 Okay. Okay. Can you go to the next slide, please? Did you ask the patient to try drugs? Okay. So the doctor did MRI in order to get her fear away. And I will explain why the doctor did that. Next slide, please. So, was that MRI cost effective? This MRI is actually cost effective because the patient is a doctor. She's very scared that she's having a brain tumor. She will go from a doctor to another just to get this imaging. And she will spend a lot of money in doctor's appointments. So, getting her MRI in this appointment will definitely be cost effective. As for the second question, was it in the interest of society? It was in the interest of society because she has patients to treat, and she, while being scared that she's having a brain tumor, she won't be able to focus. As for the risks and benefits, of course, we as doctors should weigh risks and benefits, whether it's regarding treatments or investigations. Now, in this patient, negative MRI and indomethacin treatment saved her effort and money. Could any guidelines have helped this patient? There's no guidelines that could have helped this patient because, as we mentioned, this condition is actually diagnosed clinically, but it wasn't helpful because she wasn't reassured by this diagnosis. And then after she got a negative MRI, she was eventually very reassured, and she was treated with indomethacin. Next slide, please. Now, take-home message from this last case: sometimes doctors should do everything in the interest of the patient without regards to the cost or societal considerations. Thank you.
Thank you so much, Dr. Isra, for your presentation. And it was really interesting because it brought upon like a dilemma that most doctors would have regarding, do we do imaging, do we not? What is the ethics? So it was really interesting. Thank you. If anybody has any questions for Isra, you're welcome. Please go ahead and ask her.
Thank you for excellent presentation.
Thank you so much.
Okay, great. It doesn't seem that anybody has any questions. Do you have any comments, Dr. Nader?
No, I'd like to thank all the presenters. So we will have Dr. Miqdad, I think next, or data analysis.
Yes,
Hi,
Dr.
Dr.
Miqdad is
Nader and
next.
everybody.
Yeah.
Hey, salam alaikum, everybody.
Hello, Dr.
Try
Miqdad.
to... Hey, Dr. Nader, how you doing? I'm so
Very
happy
good.
to be back again with you.
Happy to see you again. Thank you.
Thank you so much for the great invitation. Let me try to share my screen, if you don't mind.
Oh, sure. Just give me a second.
Sure.
Try it now.
Yes, now it's working. Can you see the presentation, guys? Everybody?
Yes.
Yes.
Okay, good.
Yes.
Good. So today I'll be speaking shortly. I won't be long about nephrology fellowship. I want to speak also about the reverse pathway, how to do a fellowship and then doing residency. And shortly I'll speak on how TGRF program would help you guys and help me in securing a residency or a fellowship position. So in a nutshell, nephrology fellowship is 2 years, and the main coverage of your training will be inpatient service, where the consult could be divided. I mean, depends on the program, but could be divided to ICU consult. Sometimes you will be assigned to cover the emergency admission, sometimes the floor, and sometimes dialysis consult. So it depends on each and every program, but the main bulk of the training will be inpatient. Surely the majority of programs would have an outpatient clinic. At least I would say at least one day you'll be covering a clinic where you will be able to see a CKD follow-up, for example, under the supervision of the renal attending. Now coming to the outpatient dialysis training, it really depends on each and every programs because not every program would have their own dialysis unit. But if they do have, you will be able to monitor those patients. And actually you will be treating those patients as you are the primary physician. You will do a monthly labs, you will monitor for anemia, electrolyte imbalance, thyroid, and filling the medication if so on. More importantly, transplant, but not to that extent because transplant is having a separate 1-year fellowship after doing nephrology. So, for example, in my program, we are doing 1 month every year. And maximally, I would say, to my knowledge, 2 months per year, not more than that. Doing research, not really a big deal, mainly in fellowship, but at least you will be, or you are required to do at least one research project. Now, during your fellowship as a nephrology, you will be able to encounter fluid or volume abnormalities, hypo and hypervolemia, electrolytes, starting with sodium, potassium, magnesium, even phosphorus and calcium as well. The main bulk of your training gonna be on AKI or CKD, either AKI or AKI complicated by CKD, or maybe stable CKD or CKD progression, and to less extent, tubulointerstitial disease, which is, I would say, quite often, but you will be able to see it, like a couple of cases at least during your 2 years of training. Anemia of CKD is a huge topic in nephrology because, as we know, starting from CKD 3 and going beyond that, the kidneys starting to produce less and less EPO, causing anemia. So you will be the responsible physician for treating those kind of anemia. Tanvir, if you don't mind to mute your mic. I'm sorry. So yeah, especially those with dialysis, with end-stage renal disease on dialysis, you will be able to handle the anemia from A to Z by
Excuse me.
giving EPO. Yeah, sure.
You can click on the participants and you can mute, I think, the third person on the list.
I think I can carry on.
Tanwir is the one you need to mute on the participant list.
I think she is muted now. Yeah, she's muted. Okay.
Thank you.
Thanks. So back to anemia, especially those patients with end-stage renal disease on dialysis, you'll be handling the management of anemia from A to Z, whether you give EPO, whether you give IV iron, and sometimes even vitamin B12 injections in the dialysis unit. I wouldn't say quite unusual, but you will encounter a lot of paraproteinemia or plasma cell dyscrasia, dyscrasia patients, for example, patients with multiple myeloma, because sometimes multiple myeloma could be diagnosed by a nephrologist with the AKI, with unexplained AKI and anemia or progressive CKD. There is no obvious signs like hypercalcemia of myeloma and lytic lesions. So we could be dealing of any kinds of paraproteinemia like MGRS or MGUS. So you will be closely working with the hematologist for those kind of patients. Mainly in the setting of ICU, you will be handling acid-base disturbances, complex or mixed metabolic acidosis, even alkalosis, and directly managing them with the ICU team. Dialysis. As a nephrologist, you will be able to know each and everything about dialysis, starting from the basic principles, going to the complications, going to how to avoid those common complications during dialysis, especially hypotension and hypertension, sometimes itching, nausea, vomiting, maybe fever sometimes. So dialysis is the main, I would say, this is the money machine for a nephrologist. So this is where the money goes. Maybe Dr. Nader could help me with the financial aspect, but as a nephrology, if you want to make money, you should join like a group who own a dialysis unit and then go from there. Moving to PD, peritoneal dialysis. Not every program would have the joy of having PD training, but if you do have so, you will be able to follow those patients and write the prescriptions and know the complications. You will be closely working with the general surgery team for putting the catheter, maybe removing the catheter after peritonitis, infection, and so on. It's quite uncommon, especially in the Middle East, but in the United States, in Canada, it's an evolving and growing specialty, and there are a lot of undiscovered, and unsolved questions in the PD patients. Now, how TGRF would help you guys and help me in securing a spot in residency or a fellowship? I would say by being active research participant, this is something to be highly considered in your CV. You will be attractive to the program director because, as I say, many or majority of the programs will require you to publish at least like an abstract, case report, narrative review, for example. So being active research participant, this is very important. Of course, more and more publications will make your CV more stronger and people would hire you for that. LOR from the chief, Dr. Nader, or the director of the program as well. Now coming to ERAS, many of us would put the TGRF experience and the research experience. But me myself, and this is my personal opinion, I honestly put it on research and work experience. I used to be the team leader of the pink team, so I put it in both research and work experience. And I believe, again, to my personal opinion, that it should be fine to be in both research and work experience. Presentation skills that would master your interview, especially in the era of online and virtual interview, talking to people, answering questions, and so forth. Now, I'm sure many of you guys have heard about the reverse pathway, which is doing a fellowship, then residency. But for those who doesn't know this pathway, it's not recently evolving, but it's becoming more and more popular these days, especially in nephrology, to some extent endocrinology, geriatric, and ID, because those are the least competitive fellowships in the United States. So all what you need to do or to have actually is a home residency. I know like the majority in the Middle East would be 4 years in internal medicine. But if you have only 3 years of completion of internal medicine, you will be eligible to apply for a fellowship. And this is my pathway, by the way. I haven't had a chance to match in the residency, so I applied to nephrology and I got the acceptance. Of course, you need to be ECFMG certified. Step 3, I would say, is like the cherry on the top. It's not a strong requirement, but it would help you a lot, especially with those programs who provide H-1B visa. And many, unlike residency, the majority will provide J-1 visa, but for the fellowship, many of them will provide H-1B visa. So step 3 would be a nice addition to your CV to be done. Of course, research activities, as we say, and more importantly, commitment for 2 years. The PD doesn't want a fellow who comes for a year and then apply to residency and leave the program. He will be having a shortage, 1 spot left. So they want to make sure that if you are applying to fellowship, complete the fellowship, and then you are free to do whatever you want. If they sense that you are applying or you are planning to apply for residency, believe me, your application will be rejected. This is my email, guys. Thank you so much for your listening and for your time. Email me with any question later on if you want. If you have any question right now, I'm happy to answer. Thank you so much.
Thank you so much, Dr. Miqdad. This is great. I really appreciate coming over and sharing all these and your experience. Dr. Fatma has a question. Please go ahead or comment.
Yeah, sure. Go ahead.
Assalamu alaikum, Dr. Mohamed. Thank you very much for these informations. So I have a question. For example, I'm planning to apply for geriatric fellowship, and according to my informations, it will be only 1 year, right?
Yeah, true.
So
1 year.
still I have to have this commitment of 2 years if the geriatric.
Oh, no, I'm speaking about nephrology per se.
Oh, okay, sorry.
Nephrology,
thank you very much.
Nephrology, no problem. ID is 2 years, but geriatric 1 year, and you are free to do whatever you want after that.
Okay, thank you very much. Thank you.
Thank you. Any other questions?
I'd like to add, just for those who might be interested doing the same like Dr. Fatma, And one thing that the geriatric programs would like to see is your commitment to geriatric and your education level. So in this program, we have some teaching slides. So some of them will highlight the geriatric syndromes. So if you talk during the interview about, we learned about the geriatric syndromes, this and this, and we went through the education material from the AGS, American Geriatric Society, this will put you in a higher level compared to someone who have no idea about geriatric. Because back home, sometimes we don't have good experience about specifically geriatric population. Thank you.
Thank you very much. Also, I will be involved in the master's regarding geriatric till I finish my steps. So this, you think this will be helpful? Or it will be like something supporting?
Sure.
Okay, thank you very much. I will contact you later. Thanks.
Any other questions for Dr. Mohamed? Dr. Martha, please go ahead.
Hello, Dr. Ahmed. This is Dr. Amrata.
Hey, Dr. Mohamed.
I wanted to ask you, in the RAS application, will it be okay if we include the telemedicine geriatric fellowship and postgraduate training?
This is a tricky question. Dr. Nader maybe would be able to help us, but I doubt that you can do it. What do you think, Dr. Nader?
Yeah, it's a training, and you already finished your medical school, so it's actually postgraduate. So in the US, and there are different postgraduate fellowships, and these are paid by the government, but in our program, it's voluntarily. So we are not gonna pay you, or we are not asking you to pay as some of the master program, for example, in some institutions. So it's as Dr. Mohamed said, it's a tricky, but you can mention it. And when you explain it during the interview, you will say that you are learning, and this is what we did, 1, 2, 3, 4. And this is what I'm gonna bring to the program. If it's a residency program or fellowship program, what you learned from our program here, you mentioned that, and it will help you become a fit for that program, and hopefully you will help that program. Thank you.
Got it. Thank you so much, Dr. Nader.
Any other questions, guys? I just typed my email to the chat. If any one of you would have any questions, any advice, any help regarding the reverse pathway, please be my guest. Seems no. I see a question in the chat related to what I mentioned, but will a master degree help like clinical informatics program? It would help like in your residency application, fellowship application, help in what specifically? I believe so, right, Dr. Nader? Any addition to the CV would increase your chance for the match.
Agree.
Okay, all clear.
So I don't think there are more questions, but if you have any questions, please email Dr. Miqdad. Thank you so much for coming over. And again, we are very happy to have you. Thanks, and we wish you all the best.
Thank you so much. Have a good day, guys. Thank you, Dr. Nader.
Thank you. Really appreciate it.
Thank you, Dr. Miqdad. We're gonna go now to topic 4. This is with Dr. Minnu. She's gonna be doing a tutorial and explaining about data analysis on Excel. Dr. Nader, if you can make her the host so she can share her screen. Thank you.
Right now, please.
Hi, Dr. Nadir and my colleagues. Dr. Nada, can you see my screen?
Yes, we can.
Okay, yeah. So good afternoon, everyone. Like today, I'm going to deal with a topic like data analysis on Excel. Thank you, Dr. Nadir, for giving me the opportunity to present. And thank you, Dr. Nada, to support me through the journey. And also, I'm giving thanks to my husband, who is an IT. He's an IT. He was helping me to work with the Excel sheets. So now going into the presentation. Okay. Yeah. So basically, this data analysis in Excel is very helpful when we are dealing with, like, for example, I'm working in a place where, like, I'm volunteering in the data analysis of preventive care. So patients who are taking screenings, like health screenings, for example, the diabetic eye screening and all. So from the data we are working on, there are supervisors who consolidate the data with the help of Excel sheets to analyze how the healthcare system is working, whether it is going the right direction, and they give the interpretations. So in that way, this data analysis can help you. So hope you all will be taking the output, like it might be helpful for you. So I'm going to talk about the fundamentals of data analysis. So it has 4 parts in my presentation. One is like the transform the data sheet, which we already have. So the data set I'm using is from a video I was going through in YouTube. So they had a particular set of data. So I will show you as a demo soon after my slide presentation. So it will be more kind of a demonstration rather than going through the slides. So you will be experiencing how we do that. So first thing is like transforming, clearing the unwanted parts in our data. Second part is the statistics part. We analyze, we do the formula, use of formulas and shortcuts and consolidate the data. And the third part is analysis using the charts. Descriptive analysis is the, there are different formulas for that in the Excel. And finally, we can present everything in the form of a dashboard. We get conclusions from that. Okay. So these are the shortcuts and formulas. I'm not just going through the formulas. This is just for the audience. They can use it later. I'm right now going into my demonstration part. We will be using each of these shortcuts and formulas on our way. And I will show how we work on Excel. Okay, is that clear to everyone? I hope it's clear.
Yes.
And I'm moving to, yeah, the data part. Okay. So this is the data which we have. So this data is based on the products, like the food products which have been sold by different managers on particular dates. This is a price chart. This is a quantity they sold out. And this is the type of purchase. And this is the type of payment method they used. Okay. So this might be, we might have seen this on our day-to-day life while we go buy our food. So this is kind of a sample data. Now, first, we are going to, okay. first we are going to make this data into a form of table, okay? So for that, we need to select the data. So how we select is like click on the first cell and then using the shift and the right arrow in our laptop, we are moving to the right, okay? And then press Control and Shift together and we go down, we select the whole data together, okay? And then, as you can see my screen, just after the home, there is Insert, okay? Insert, and then we have Table, okay? So we are going to create the table for our data, okay? So this is a data table we are working on. And as we see, we can see our manager list. It's not arranged in a very well order. So we can do like, we can make it in order without much spaces. So how can we do that? Okay. So for this, we select the manager, one of the manager's name. Okay. And then go to the cell where we are going to work on. And the formula, the shortcut is press equal. And then there is a formula called trim. Okay. This is the formula, trim. And then there will be an open bracket. Okay. And then click on the manager. And yeah, 1 second. We are closing the bracket. Okay. Then tab. When we press tab, the whole manager list will be coming in an orderly way. Okay. Now we can select this and Control C. We are copying it and then moving to the manager, right click, and we are doing paste special, the values only, so that it will be moved to this side. We can remove this by selecting the data, and then we can delete the column J. Okay. And we can rename this like manager. Okay. So that part is done. Now, as we go through the data, you can see the quantity, like the quantity of the fries, beverages. There are like kind of decimals here. So we can remove the, kind of round up it. So what we do is, this is a place we are going to plan it. So we can use a similar way. Every time we use a function in Excel, we try to put like the equal, and we are going to do round up. So round up, and the open bracket comes automatically. And then we click on the quantity, one of them, and then close the bracket, and then press tab. 1 second. One more thing I need to do. Second. Equal, round up, number, comma, 0. So that, yeah, okay. And then we are putting 0 because like it will be a whole number kind of, and then tab. So you can see 573.07, it's like rounded up like this. And then we are selecting this, right click, copy, and paste here. Paste special, that is the values only. Okay. And then we are removing this. Like delete column J, and then we are renaming it quantity. Okay. So we kind of cleared it. And one more thing I would like to add is like there might be duplicates in our data when we are doing the data analysis. So for that, what we do is we select the whole data. Okay. So for that, shift right arrow, we'll select horizontally and then control shift together and go down. The whole data will be selected. And then in data, you can see, can you see this? There is an option for remove duplicates. So we selected all the columns and we saw 5 duplicate found, removed. So there will be unique values along. Okay. So data is almost good. I would like to add one option that is, here we have cities, right? So in case, if you would like to add in some data which you're working on, if you would like to add the country in which the city is, there is an option for that. I'll tell you. So select the city column and then, okay. And then in second. Okay. As we select, you can see under the data, there is geography. Okay. So if we click geography, you can see there is a small link opening. Okay. So if we click that, there will be a drop-down menu where country comes. Okay. So if you click that country, there will be the country coming up where each city is there. So Berlin in Germany, like that. Okay. Yeah, but for maybe because of my Excel, which I'm working on, they have been updated about Paris. So I'm not using that right now, but definitely there is option for that. So I would like to show that to you. At present, I'm deleting this column. Okay, so as now our data is clean. Now we are going to work on the second part, which we already talked about, that is statistics. So in statistics, let me just pull out data. Okay. Okay. So as we take home, for my Excel, I already downloaded the tool pack. Tool pack is the one which is working on, for example, to find the mean, standard error, all the statistical things which we are going to work on. If you have this option in Excel, you just need to click in. Okay. Some Excel tools may not have it at the first time itself. So you may need to add in. So the path is all, I have mentioned about it in my presentation. I will definitely share it with you, but I will tell you right now, like there is add-in option. In my add-in, since I'm already added my tool pack, it won't come up. But for you guys, if you're adding in, there will be an option for tool pack. And if you click it, this option will be available always. Okay. If it's not seeing, you may have to go to your file options, and there will be tool pack in that option. And it will be coming automatically to your taskbar. Okay. So for our data, for example, our price, I'm going to find the statistics of price as well as the quantity of food items. So I'll show you how am I going to do that. So for price column, I'm going to select this. One second. Okay. Okay, I selected the price column and now I'm going to click the tool pack. So there will be multiple options coming up. And then you can click the descriptive statistics. Okay. If you click the descriptive statistics, they will ask for the input range. So I will click that. During that time also, you can apply the, you can select the price. So that is, yeah. So you can see the input range is added. And now I'm removing the labels in the first row. And the output range is a place where I would like to see my data. 1 second. Yeah. So I'm going to click a new cell. Yeah, 1 second. Yeah, I'm going to click a new cell a little bit away here. Okay. And then I'm just pressing the OK. So you can see, I'm just renaming this. This is the statistics for price. Okay, so you can see the mean, the median, mode, the minimum range, maximum range, sum, all those things. Okay, so similar way, I would like to do that for the quantity also. So I just click the first one, show toolpack, descriptive statistics. I'm going to add the input range. So selecting it and, oh, 1 second. Okay, selected. And labels in first rows, the output range. Second, I would like to go up. I would like to go a little bit further away. Okay. And I click the output range location. And now I'm moving to the OK button. So this is the statistics about the quantity, for quantity of the food items we saw. Okay. And now we can depict this in the form of our box and whiskers graph. So for that, what we can do is we can select okay, 1 second. I would like to move this price near to the okay. I would like to move the price near to the manager because in one chart I would like to add the price. Price and manager together. Okay, so it will be easier to select together. So I will show that. So first thing I'm going to do is like select this, select the price. And if we go to the taskbar, like insert, and you can see different ways we can depict in the form of charts. And I'm using the statistical, the box and whiskers. Okay. So this is how we depict the price in the form of chart. Okay. So here, as you can see in the picture, this is the median range. This is a maximum, minimum, the outliers, and this is a most of the variables come over this area. And similar way, I would like to add each manager who sell in this chart along with the price. Okay. So for that, I'd like to go up a little bit. And then here I'm going to select the manager and the price together. Okay. Okay, so we selected both. And the similar way we are inserting the statistical, we are in insert statistical, and we are using the, also we can just, yeah. So you can see each manager with the price. Yeah. So you can depict both. The similar way, I'm just giving you an example. The topic which you're working on, the data analysis, you can include whichever variable which you would like to add on the graph. So based on that, you can work. So I would like to move this. Okay. So that part of statistics is over now. I would like to add one more thing to our data. That is a revenue. Okay. So how do we find the revenue from each? Okay.
Minnu,
Yeah.
if you can click on the participant and you can mute Dr. Rehab. She's the
Okay,
second.
sure.
And thank
Okay.
you.
Yeah, thank you. So now we are going to find the revenue. Okay. So to find the revenue, it's similar. We use a formula equal. Then we need to find the, like, how do we find the revenue? Like, it's price multiplied by quantity. Okay. So we multiply price, okay, star quantity. And close the bracket. 1 second. 1 second. Let me just. Yeah, should be fine. Equal price by quantity. Yeah. So, and just press tab. Okay. So the revenue comes down. Okay. This will be useful for next section. That's why I just created that part. Now we are moving to the data analysis part, which is used, where we use the pivot tables. So how do we do that? Okay. So for this, we need to select the entire data. Okay. And we are going to create pivot tables to understand, by adding different variables, we can understand our data and we can make interpretations. Okay. So, okay. Second. Yeah. So we are going to select the whole data. That is shift right and down. So we selected the whole data. And now how we can make the pivot tables. Go to the taskbar, like we have the insert button, and below that you can see the pivot table. Okay. So yeah, table. And we need, using the existing worksheet, and we need a location. So I'm moving my sheet a little bit away and I'm clicking here, this as a location, this new cell as a location. And then if I press OK, there will be the pivot fields, table fields coming up. Okay. So in this, we are going to input as such, like depending upon our scenario, we can add different variables here in the form of like, okay, for example, we have, okay, while we analyze the data, we have certain questions, to, we create some questions to understand our data. Okay. So I have created 3 questions. So that is, 1 second, I'll show that. I would like to minimize this. 1 second. Yeah, okay. So these are the questions I have created based on our data. So we need to find what is our best-selling product, okay? And what is our total revenue? What is our revenue breakdown by the payment method? Okay, so first thing we are going to analyze with our pivot table is what is our best-selling product, okay? So I'm just pulling up my sheet. Yeah. So here I already inserted the pivot table. Yeah, so this is when I click, the pivot table fields come up. So the best one. So I'm just adding the quantity. BJ. Sorry, 1 second. Yeah. One second. So our question is, what is our best-selling product? Okay. Okay. So the product type. We need to remove this quantity to the sum of the quantity. Okay. Okay. So the product and the sum of the quantity. So we can see in our cells we have created the beverages, burgers, sandwiches, all these things, the sum of the quantity. And if we are sorting it out in the form of descending order, we can see like beverages are the best-selling product. Okay, so similar way we can use our variables depending upon our scenarios. Okay, so the first question is over. Next question is like, what is our total revenue? Okay, so for that, we are going to create another one. So we can see the field pivot table fields. In that, we need the revenue. We are just removing this. And we just need the revenue alone. Okay. So you can see the sum of the revenue. Okay. And then what is the revenue breakdown by the payment method? Okay. So for that, show the field list based on the payment method. Just select payment method and revenue, then close it. You can see this is the based on each payment method, this is the revenue. And if you'd like to sort it out, like sort and descending. Yeah. So with the credit card is the sum of the revenue, the maximum. And I would like to show you in the form of dashboard, there are two functions which are, it's like a little bit higher level, but I will just give you the formula how to find it out. So with that, we can find using our data. So for each manager, for example, the manager named Tom Jackson, who is selling the product fries. Okay. Yeah. He is making this much of revenue. Okay. So if we apply this data in case of Excel with a formula XLOOKUP function, okay, we can find the next time if we are looking for another manager, if we just add the manager's name, automatically the product will come up, the revenue will come up, like it's like very automated form. Okay. So I will show you the formula in my presentation. Okay. So this is a formula. So I'll a little bit explain about XLOOKUP. So XLOOKUP function to find things in a table or range by row. For example, look up the price of an automotive part by the part number or find an employee name based on the employee ID. Okay. With XLOOKUP, you can look in one column for a search term and return a result from the same row in another column, regardless of which side the return column is on. So going back to my demo. So the formula is like, first I would like to select the manager, Tom Jackson, and then I'm just putting new cell, word, X. Select manager first, and then we add his name. We use equal XLOOKUP. And then we select the whole manager list together, comma, and then we are going for the one second. We are going for the product next. And as much of criteria like we need, we can add after putting like comma. Okay. So I'll show that 1 second. So similar way. Yeah. 1 second. Okay, 1 second. Yeah. So I have worked already on my data already to save the time. I'm just adding. So my previous work data. So here I selected the manager and they have the city already. And this is the revenue from each one. Okay. So with the formula, which I already said, like equal XLOOKUP, the bracket opens, the manager, add the manager part, comma, the city, comma, the revenue, and close the bracket, you'll be able to find the data like this. So what the use of it is, if we change the manager name by selecting, for example, if I'm selecting Joa Silva, automatically the city name changes, the revenue changes. Okay. And if I'm selecting Pablo Perez, okay, and adding the manager part, you can see the city changes and the revenue changes. So it helps in like automate most of the data. It will be much easier to find interpretations or like, yeah, conclusions from that. Similar way, we have higher functions, that is like sum if s, okay? So it is one of the math and trigonometry functions, adds all of its arguments that meet the multiple criteria. It works similar to the lookup, X lookup. So similar way, the formula is equal sum if s, open bracket, sum range, and we add the criteria. So similarly, in my, the revenue of each one can be understood by changing the manager. So we created we used lookup as well as sum if s to show you the dashboard like this. Okay. So yeah, that's all about my presentation. I know it might be a little bit confusing at the end part. You don't need to worry about it because I have created the slide. I can share that in our group, and it has all the shortcuts I have used, like creating the table, arranging it in the order, rounding up the country, the copy paste and all, the descriptive analysis, how to go, the route to go to the descriptive analysis, then the data analysis, how to create the pivot table, sorting it out, and using the X lookup as well as the sum ifs. Hope you will be able to use it while you're doing the data analysis, and hope it will help you guys. Thank you so much.
Thank you so much, Dr. Minnu, for this great presentation and demo. And usually, most of the papers, when they talk about the demographic of their sample, they will use a table, usually the first table, table 1, and it will have some of the demographic of the either the intervention group and compared to the placebo, or the comparison between the control and the group that they tested. So it's important to understand how to come up with this data in a table format from raw data, as Dr. Minnu showed us. Thank you so much.
Okay, hope it helps because I didn't know this much of uses there for the Excel in data analysis, but I recently came to know when I was analyzing, when I was working in a patient screening area, how this, as I said before, so a lot of data though. So my supervisor was working on concluding the data, those patients who have undergone the screening and finding the percentage from that and analyzing it. So I felt oh, this is a good tool, but I'm still learning it. So if somebody have any doubts as of my presentation, I can clear it. But it's a very big tool. It has a lot of enhancement, lot of options we can work on, and it's a very good tool. Yeah. Thank you.
Thank you once again. Really appreciate it.
Thank you, Dr. Minnu, for the great presentation and tutorial. And Excel could be challenging for a lot of us, so thank you for simplifying it as much as you can.
Yeah. Thank you so much. For supporting me.
You're welcome. So if anybody has any questions, please feel free to ask Dr. Minnu. If not, we can go to the other topic. Let's check first the chat. Okay. No questions so far. Dr. Nader, if you can make me the host, I'm gonna share the screen. For the other topic, it's gonna be about the leadership. We have Dr. Reem and we have Dr. Lojain. They're gonna present about the topic.
Hello, everyone. My name is Dr. Reem Saifaldawla. Thank you, Dr. Nader and Dr. Nada, for this opportunity. Me and Dr. Lojain are going to present some basic information about leadership, how to be a good leader, and what are the obstacles in front of the good leader.
Okay, we are going to start by who is the leader? The leader is a person who is sitting in a group, and he is the one that inspires and encourages other people towards achieving a specific goal. Without the leader, the group will work incoordinately and there will be chaos, and at the end, the goal won't be achieved. As written here, the leader is the one who inspires and develops followers. He set the goals and obligations for the other people in the group. He accomplished the work and he overcome the obstacles. Okay. What is leadership? Leadership is the process of influencing other people so that they can work at a higher level than their normal capacity and their performance in order to achieve the desired goal. Influencing people so that they will strive willingly toward the achievement of the group's goal and lifting the performance to a higher standards beyond their normal limitations. Let's see what are the main leadership traits or skills. First, intelligence. It's very important that the leader to have high intelligence, and he need to have good social skills and to be adaptive to the surrounding environment. He need to be competent and he need to be ambitious and he need to be initiative and self-confident. He need to be creative and he need to have a good decision-making skills and to be honest and be open-minded. Let's talk about the 7 effective ways to develop a leadership skills. Okay, first, you need to have a good critical thinking. You need to set your goals and have a future vision. You need to work on the communication skills and your speaking skills. You need to build the team spirit and encourage the other people working with you. And you have to encourage them and recognize their efforts and to match the individual skills and all their work and encourage them to work cooperatively. You need to make sure that the work is done correctly on time, and you need to be an organized person, and you need to trust your colleagues and encourage them so they can move forward. Okay. Thank you. My Dr. Lojain is going to continue the presentation. Thank you so much.
Hello, everyone. This is me, Dr. Lojain. I'm here to continue with the leadership journey that my colleague Reem started. First of all, I want to thank Dr. Nader for this great opportunity, and the thanks expand to Dr. Nada for hosting. So I will be sharing information on different leadership style, offering tips on being a great leader, and discussing the causes of leadership failure. Now, looking forward to sharing this with you all. Okay. I will start with leadership style. Leadership style refer to the different approaches leaders use to interact with their team members, make decisions, and inspire their followers. This style can vary greatly depending on the leader personality and organizational culture, the specific situation at hand. Understanding different leadership styles can help leaders adapt their approach to be more effective in various contexts. There is up to 9 leadership styles, but here I will mention the most common recognized leadership style. First one is autocratic leadership style. In this style, the leader has complete control over decision-making and rarely seek input from team leader. Autocratic leader give instructions and expect them to be followed without question. And this style can be effective in the situation that require quick decision-making or when the leader is the most knowledgeable person in the group. However, it can lead to low employee morale and reduced creativity. The next leadership style, democratic leadership, or we can call it participative leadership style. In this style, leaders involve team members in the decision-making process. They encourage open communication and value the input of their team. This style can lead to higher employee satisfaction and commitment, as team members feel that they have stake in the outcome. It's particularly effective in environments where creativity and teamwork are important. Now let's jump to the next style of the leadership. It's a laissez-faire or delegative leadership style. Here, the leader take a hand-off approach, allowing team members to make decisions and manage their own work with minimal intervention. This style can foster independency and creativity, but can also lead to lack of direction if team members are not self-motivated or if clear goals are not established. The next style of leadership is transformational leaders who inspire and motivate their team by setting high expectations and encouraging innovation. They focus on developing team members' abilities and are often seen as a role model. This style can lead to significant changes and improvement within an organization. The last and not least style of the leadership is the charismatic leadership. Here, the leaders are inspiring and energetic, and they use their charm and persuasiveness to motivate their team. They often have a clear vision and are able to communicate it in a way that generates enthusiasm. While charismatic leaders can be very effective, their style can sometimes be manipulative or lead to unrealistic expectations. Now, let's flip the board to talk about how to be a good leader. Here are the 7 tips to be a good leader. The worth mentioning point here is becoming a good leader is a continuous process that involves developing a combination of skills, qualities, and habits. And here are the 7 steps or tips may attribute to be a good leader. First one is the self-awareness. You should understand your strength, weakness, values, and emotion, and this reflects on your behavior and its impact on others. Self-awareness is the foundation of emotional intelligence, which is a crucial step for effective leadership. The second tip is continuous learning. As we know, the good leader is a good reader. So try to commit to lifelong learning, read books, attend workshops, and seek mentorship to gain new insights and perspective. Stay informed about your workplace trends and best practice. The third tip is motivation. Try to understand what motivates your team members and use this knowledge to inspire and encourage them, recognize and reward good work to boost morale and productivity. The next tip is vision and inspiration. You should have a clear vision for the future and be able to inspire others to work toward it. Communicate your vision effectively and align it with the goals of your team and organization. A good leader should be a good communicator, so try to develop strong communication skills, both verbal and nonverbal. Learn to listen actively, express ideas clearly, and tailor your message to your audience. Good communication fosters understanding and builds trust. The next is conflict resolution. The good leader usually is a good problem solver. Try to develop skills to handle conflicts constructively, address issues promptly, encourage open dialogue, and seek win-win resolution that respect all parties involved. Also, the good leader is a good decision maker. Try to improve your decision-making skills by gathering information, considering different perspectives, and weighing the pros and cons. Be decisive, but also willing to admit mistakes and learn from them. Now let's move to talk about what will lead to leadership failure. Leadership failure can stem from a variety of causes, often resulting from a combination of personal shortcomings, strategic missteps, and external factors. And here are some causes of leadership. We try to use the fishbone model or diagram to demonstrate the causes clearly. At the head of the fishbone diagram, there is our problem, which is the failure to lead, and the skeleton show us what are the causes of the leadership failure. Let's start with ethical failure. Ethical failure often involve ethical lapses such as dishonesty, corruption, or abuse of power, and these actions can destroy trust. The second cause is inadequate crisis management. So as we mentioned earlier, the good leader should be a good problem solver. So any leaders who are unable to effectively manage crisis, whether they are external threats or internal scandals, can quickly lose the confidence of their team and stakeholders. The next is inability to adapt. The environment of work is constantly changing, and leaders must be able to adapt to new challenges and opportunities. And those who are rigid in their thinking and resistant to change can lead their organizations into decline. Ignoring feedback, and this is a result from overconfidence. So any leader who are closed off to feedback, whether from their teams, customers, or other stakeholders, miss out on valuable insights, and that could help improve and avoid mistakes. As I mentioned earlier, the good leader should be a good communicator. So, effective leadership relies on clear and consistent communication. Failure to communicate goals, expectation, and feedback can lead to misunderstanding, decreased morale, and poor performance. The next cause, and I think it's one of the important causes of leadership failure, is that the leader fail to attract and retain talented members. Any leader who fails to recognize the importance of talent who create environment that drive away top performance can find their organization weakened over time. The next cause is the lack of vision. The failure to articulate a clear and compelling vision struggle to inspire and to guide their team. This is considered one of the major causes of leadership failure. Without a shared sense of purpose, organizations can become directionless and demotivated. And last but not least, it's a poor decision making. Good leader is a good decision maker. So any leader who is consistently making poor decisions, whether due to lack of information, bias, or host, can lead the organization into crisis. So these are some of the causes that might result in leadership failure. And with that, our leadership journey comes to an end. I hope all of you enjoyed this presentation. Thank you so much.
Thank you so much, Dr. Reem and Dr. Lojain. We're going to see if anybody has any questions regarding the presentation. If you do, please raise hand or feel free to share in the chat. Great. So far, we've come to an end to our presentation so far for today. We have had 9 presenters, so I want to thank everybody for all of their hard work today. And thank you, Dr. Nader. And if you have any feedback, that would be great as well. Thank you. Now we're going to go to the project. Yeah.
Yeah, thanks to all the presenters. Thank you to your team. Any updates?
Thank you, Dr. Nader, for the opportunity.
Thanks. Any questions, updates, or any new ideas? Dr. Haifa, go ahead. Thanks.
Yeah, well, thank you, Dr. Nada, and for your team for the great presentation. And thank you, Dr. Nada, for responding to my email regarding the abstract that I worked with my team. I just have a question regarding the submitting to a conference. So, do we have to be through, for example, university, or like we can do it through the, for example, this geriatric fellowship, because it's just about the pediatric and I don't know how to,
Yeah, most of the time the conferences, they have their own guidelines, and most of them they will accept unless they ask you a few questions about affiliation or something like that institution. But otherwise, they will accept the abstract. So see.
Yeah, so do we have to do it through the fellowship like a research fellowship with you, Dr. Nader. So I mean, like,
Yes. Yes.
yeah. So if you don't mind, could you please give me your contact information and for example, the institution or whatever, the university, or how the way that you would like us to submit it.
So if you want to put my name or the Gmail email address, and the Telegeriatric Research Fellowship is a program. So these are the three, I think, common information that they need.
Okay. Thank you very much. I really appreciate it. Thank you very much. Thank you, and hope we will be accepted. Thank you.
Good luck. Yeah, I wish you all the best. Thanks. Good
Yeah,
work.
thank you very much. Thank you. Good luck. Okay, thank you. Bye.
Dr. Isra, go ahead.
Assalamu alaikum, everyone. I hope you guys are having a good day. I just want to give you a few updates about our projects within this program. Me and some fellows were working on 2 systematic reviews, and we submitted 2 abstracts for the American Heart Association, and we're waiting for the emails of acceptance, inshallah, hopefully during the month of July. Regarding abstracts, we submitted 2 abstracts, one for Canada and the other in America, Atlanta. Both of these abstracts are featuring the mobile applications the fellows were working in during the past year. One is about the INR guard, and the other is about smoking cessation. I'm excited to share the news that both of them are accepted and will be presented during the month of September, and the other one will be on October. I want to thank Dr. Nafisa Mustafa and Dr. Amal Al-Amin. They're the developers of these 2 apps. We worked together to submit these 2 abstracts, and thankfully they got both approved. I also like to thank Dr. Nader so much for his support, for his guidance, and I would like to encourage other fellows to reach out to if they have any questions about how to write a proper abstract, if they have any questions in submitting to conferences. Of course, Dr. Nader is always helpful, and his guidance is very much appreciated. And good luck to everyone.
Thank you so much, Dr. Isra, for the update, and congratulations. Excellent, good work.
Thank you very much.
Thanks.
Yes, I can leave my email in the comments.
Any other updates or any other questions, comments? If not, I'd like to thank you all for attending, and thank you so much, Dr. Nada, and your team for great meeting and for moderating and presenting. Thank you all, and I wish you all the best. If you have any questions, please email me or contact me, and I'll be happy to help. I wish you all the best. Have a wonderful day or have a wonderful night. Assalamu alaikum.
Thank you, Dr. Nader.